Students, welcome back to our series of lectures for the treatment of angina. Today we will be discussing about the factors which are governing the oxygen demand and the supply of the oxygen to the myocardial cells in angina pectoris. Just to have a quick review of what we have discussed in the previous session, now it's very clear that the angina, that is a pain in the myocardium, is because of the mismatch between the oxygen demand and the oxygen supply. So we need to go into the detail of the factors governing the oxygen demand and the factors governing the oxygen supply, because once you understand these factors in depth, you will come to know that which drugs are acting on which factor and how they are reducing the oxygen demand and how they are improving the oxygen supply. So in this discussion only you will come to know the various classes of the drugs which can be used for treatment of the angina pectoris. Let's start one by one. The first part, that is how we can reduce the demand of the oxygen by the myocardial cell. So the first factor which is responsible for increase in the oxygen demand by the myocardium is the contraction. You can see that there is a direct relation between the contractility and the blood supply. If the contractility of the heart increases, it will demand for the more amount of the blood to be supplied to the myocardium, because the contraction is a physical phenomena which includes the coupling of the actin and the myosin, where the coupling needs the energy and therefore there is a breakdown of the ATP molecules. So energy generation becomes very important and hence the oxidative metabolism increases. And when the oxidative metabolism in the myocardium is increasing, obviously the oxygen demand by the myocardium will increase. Now in this situation, if you want to reduce the oxygen demand, we have to reduce the contractility of the heart. When we want to reduce contraction of the heart, we have to understand the mechanism of the contraction of the myocardium. So whenever an impulse reaches to the ventricular myocardial cells, what happens is that there is a phase zero, that is an opening of the fast sodium ion channel. Due to the entry of the positively charged ions, the membrane potential shifts to the positive side, spikes to the spike action potential of 20 millivolt, which leads to the closure of the fast sodium channels and leads to the opening of the slow sodium ion channel and slow calcium channels, or which we call as the L-type calcium channels. This entry of the calcium into the myocardial cell triggers the release of calcium from sarcoplasmic reticulum, and this calcium is responsible for activation of an enzyme called as myosin light chain kinase enzyme. Being a kinase enzyme, it brings about the phosphorylation of the myosin light chain, and activation of this or phosphorylation of the myosin light chain leads to the coupling with the actin. Actin myosin couple with each other and that leads to the forceful contraction of the heart. So if we are able to restrict the entry of the calcium into the myocardium by using the drugs like calcium channel blockers, we will be able to prevent the activation of the kinase enzyme leading to the phosphorylation of a myosin. So this is how we can reduce the contractility. So there are certain class of a drug called as calcium channel blockers, which include amlodipine, nifedipine, dihydropyridine derivatives, even diltiazem and verapamil having a more affinity to the L-type calcium channels, which are specifically located on the heart or on the myocardium. So these class of the drug will be useful over here. At the same time, when you understand the physiology of the contraction of the myocardium, we know that there is a activation of the, or there is a phosphorylation of a myosin. So if we reduce the phosphorylation of the myosin, or we dephosphorylate the myosin by increasing the levels of the cyclic GMP, also we can reduce the contractility of the heart. And a nitroglycerin exactly works by this mechanism. Another factor which we cannot miss out, which is also responsible for increasing the contractility of the heart, is the sympathetic nervous system. The adrenergic receptor located on the heart, that is a beta-1 receptor, is responsible for its positive ionotropic and chronotropic effect. The positive ionotropic effect triggered by activation of the beta-1 receptor can also be reduced by blocking beta-1 receptor. So here comes the role of a beta-1 selective or cardioselective beta blockers for reducing the contractility of the heart and therefore reducing the oxygen demand by the heart. So if we want to reduce the contractility of the heart, we have three classes of the drug. The drugs which are blocking L-type calcium channel, which are calcium channel blockers. the drugs which are blocking beta-1 adrenergic receptor like cardioselective beta blockers, and a drug which are increasing the cyclic GMP level like nitrates. The second factor which is important is the heart rate. Heart rate is a very important factor because when there is an increase in the heart rate, there will be a heavy load on the myocardium to compensate with the increased beats, number of beats per minute. And the heart may not be able to complete the cardiac cycle, or there may be the abbreviation of a diastolic period. And when a diastolic period is getting abbreviated, that means the filling phase of the heart is getting abbreviated, there won't be a complete filling of the ventricle, and that will ultimately affect the oxygen saturation of the blood and the supply of the oxygen to the deepest portion of the myocardium, like the subendocardial region. If you refer to my first session, I have told you that this is a subendocardial region, which is the deepest portion of the myocardium, likely to suffer from the ischemia in conditions like angina, where the coronary blood flow through the coronary artery is compromised due to plaque formation. Under such situation, if the heart rate also increases, then due to the decreased filling phase, due to the decrease or the abbreviation of the cardiac cycle or the diastolic period, the oxygen saturation will be decreased. In such a situation, oxygen supply to the subendocardial region may also be compromised, and that may trigger the angina. Therefore, the reduction in the heart rate can prevent such situation. So here we have beta-1 selective antagonist, a cardioselective beta blocker, which can reduce the heart rate because they are located on the SA node and the AV node. The third important factor, but the most important factor, which is having an effect over the oxygen demand, is a wall tension. It's a tension of the ventricular wall, and that is governed by two important factors, or here we can refer to the Laplace law, which states that the ventricular tension is determined directly proportional to the radius of the ventricle and the left ventricular pressure. Now here the most important factor is the left ventricular pressure, because the left ventricular pressure will be determined by the filling pressure. At the same time, it will be determined, therefore it will be determined by venous return. At the same time, it will be determined by the cardiac output also. Now, cardiac output will be determined by the aortic pressure. If suppose there is a resistance to the ejection of the blood due to the hypertensive conditions or due to the contraction of the aorta or a vasospasm, in such situation, the ejection or the emptying of the ventricle, left ventricle, becomes difficult. So that is a condition where we say the afterload is increased. And also if there is an increase in the preload, then also the left ventricular pressure is going to increase. At the same time, under a condition of angina where there is a blockade in the coronary artery, already the coronary blood flow is declined. So supply of the oxygen to the ventricular mass is declined. Under such a circumstances, the systole is not happening forcefully. So with every systole, there is no complete emptying of the ventricle, and the end systolic volume is increasing, and gradually that volume is getting added up, and that will ultimately lead to the increase in the left ventricular pressure, and that will lead to the increase in the ventricular radius, which will cause increase in the wall tension, which will lead to the stretching of the wall of the ventricle. Actin and myosin will be pulled away from each other to such a great extent that if they have to couple, contract and empty the left ventricle, they have to forcefully couple with each other, which demands a greater amount of the energy. And when it comes to the energy, there is require oxidative metabolism, and therefore the oxygen demand of the heart will increase. So if we want to overcome such a situation, we want to reduce wall tension, we have to reduce left ventricular pressure, which is possible by reducing the preload, by reducing the afterload. Let's go one by one. If you reduce both the preload as well as the afterload, what advantages we get is that when we reduce a preload, that is possible by dilating the veins. Veins being elastic, they will pull the blood and they will reduce the venous return. They will reduce the filling pressure. when we are dilating arteries, then when we are dilating the arteries, mean arterial pressure will fall down. The pressure gradient between the left ventricle and the aorta will increase, and that will facilitate the ejection of the blood in direction of the pressure gradient, that is from a higher pressure of the ventricle to the pressure which is lowered into the aorta. So with a less demand of the oxygen, there will be emptying of the ventricle, and the demand of the oxygen will be reduced, and hence in a compromised blood supply of the coronary artery, there won't be a pain. So we want a drug which can dilate vein, which can dilate arteries, and we have nitrates because they have arteriovenodilator. They dilate both veins as well as the arteries, reduce preload as well as the afterload. Also here, the calcium channel blocker drugs like dihydropyridine derivatives like amlodipine, nifedipine, which are responsible for blocking L-type calcium channels in vascular smooth muscle, especially in the arteries, will be also responsible for reducing afterload. And reduction in the afterload will ensure the complete emptying of the ventricle, thereby reducing the left ventricular pressure and therefore reducing the wall tension and therefore reducing the oxygen demand. So here, these two classes of the drugs can work wonderfully to reduce wall tension on the heart. So myocardial oxygen demand is chiefly determined by these three factors: contractility, heart rate, wall tension, and wall tension in turn is determined by preload and afterload, which we already discussed in detail. So if you have to diminish the oxygen demand, then we can reduce the contractility, we can reduce the heart rate, we can reduce the preload and afterload, thereby reducing the wall tension. Now we are coming to the second part, that how we can improve the oxygen supply. So when we look at the oxygen supply, again there are three factors which are governing the oxygen supply. The first is arteriovenous oxygen difference. The second important factor is a regional myocardial perfusion or a blood distribution. And a third factor, that is the coronary blood flow, which in turn will be determined by the vascular resistance and arterial pressure. Let's go one by one to this each factor. The first factor, that is the arteriovenous oxygen difference. Arteriovenous oxygen difference is nothing but the difference in the oxygen content of the artery and the veins. And practically we can see that it is around 4 to 5 ml of the oxygen which is always derived by the tissue per beat per gram of the tissue. So when we are talking about this arteriovenous oxygen difference, it depends upon how much amount of the oxygen is demanded by the tissue or is extracted from the blood by the tissue. So in the situations where the contractility of the heart increases, obviously the extraction of the oxygen by the tissue increases and arteriovenous oxygen difference also increases. So in such a situation, if we reduce the contractility, the demand of the oxygen will be reduced and we will be able to fulfill the requirement of the oxygen even in the compromised blood supply. Another is a regional myocardial blood supply. When we talk about a regional myocardial blood supply, it is a blood supply not only restricted to the coronary artery, because when we talk about a regional myocardial blood supply, we are not only talking about the amount of the blood flow in the coronary artery, but we have to understand that the blood flow has to reach to the deeper portion of the myocardium, because it is the entire myocardium which contracts. It's not a portion of the myocardium which contracts, but it is a whole ventricle which has to contract, and therefore there has to be a sufficient blood supply and oxygen supply to the entire region of the myocardium within the tissue up to the deepest portion of the myocardium, where these collateral blood vessels also play an important role. And these collateral blood vessels should be properly perfused, and therefore this regional myocardial blood flow or a distribution of the blood flow in every deeper portion or every layer of the myocardium has to be reconstituted. So we don't want only to improve the blood flow in a major coronary artery, but we should also have the drugs which can improve the blood flow in the collateral blood vessels and nitrates to that. They improve the blood perfusion into the collateral blood vessels, thereby ensuring the supply of the oxygen to the deepest portion of the blood, that is the subendocardium portion, thereby improving the efficiency of the heart. And the third factor, which is the most important factor, because the blockade is in the coronary artery, so how we can resume back the coronary blood flow? If we have to resume back a coronary blood flow, we have to dilate the coronary blood vessel. So we want a coronary vasodilators like nitrates, which dilates the coronary blood vessel. They enlarge the narrow lumen size. They improve the blood flow. They improve the oxygen supply to the myocardial region. So this can also be achieved by dilating the by using the arterial vasodilators like dihydropyrimidine derivatives, nitroglycerin, amlodipine, but it can be more efficiently achieved with the help of the nitrates. So when you improve the coronary blood flow, ultimately you are going to improve the oxygen supply to the heart. So from this discussion, it's very clear that oxygen supply to the heart can be improved by improving the coronary blood flow, not only coronary blood flow, but also the regional myocardial blood supply within the collateral blood vessels. So from this entire discussion, I think now, students, it must be very clear to you that which categories of the drug are going to help us for treatment of the angina. The major domains where the drugs will be acting will be reducing the oxygen demand. So we want the drugs which will reduce the contractility, where we have the drugs like beta blockers, we have calcium channel blockers, we have even the drugs increasing cyclic GMP level and reducing the phosphorylation of the myosin light chain like nitrates. We want to reduce heart rate, we have beta blockers again. We want to reduce the wall tension. We have vasodilators, arteriovenodilators, and arterial dilators. These arteriovenodilators and arterial dilators are going to reduce preload, afterload, left ventricular pressure, and therefore the wall tension. At the same time, they are coronary vasodilators also. So they are also helping us to improve the coronary blood flow. They are collateral blood vessel dilators. So they are going to improve the myocardial regional blood flow, which will reach to the deepest portion of the heart, improving the contractility of the heart and improving the oxygen supply to each layer of the myocardium. And also we have to look for the supportive treatments, or you can say alternative treatments rather than supportive, which will help to remove the plaque or the thrombus or the clog within the coronary artery, which is restricting the blood flow. So there we will have to use antiplatelet drugs or thrombolytic drugs, fibrinolytic drugs, anticoagulants, and also we'll have to use certain physical techniques like angioplasty to remove the clot within the coronary artery. So together all these drugs and techniques can help us to treat a patient suffering from angina pectoris. So in my third session, we will now start with the drugs and their pharmacology of those drugs used for treatment of angina pectoris. Thank you.